Hello and welcome everyone. Today we'll be discussing about Legionnaires disease. So what is this? It is actually a waterborne disease caused by the Legionella bacteria. It is an increasing global health problem, often underdiagnosed and underreported. Legionella is a type of pneumonia caused by this bacterium where the Legionnaires disease is called. It can occur both in the community as well as in the hospital. It has high morbidity and mortality. Early detection and management is thus very critical. Who are at risk? Patients requiring ICU admissions with Legionnaires disease is seen in around 20 to 40% of the cases. The risk factors being smoking and chronic lung disease, age over 50 years, immunocompromised conditions where chronic steroids, organ transplant, cancers and blood diseases. So as you can see, these type of patients are increasing. Our population is getting older. So obviously you will get more such patients in your ICUs. So ICU admission is often needed when the patient lands up in ARDS or septic shock or kidney injury. So where is this found? It is found in the aquatic habitats, that is water, soil, water distribution systems like that. It survives and grows inside protozoa and biofilms. That is, biofilms are essentially the coverings over the water pipes. More than 65 Legionnaires species exist, but not all can cause human disease. The most common species being Legionella pneumophila, which is serogroup 1, which accounts for 80 to 90% of the cases in the Europe and US, and Legionella longbeachii, which is common in Australia and New Zealand, and which has up to 51% of the cases there. So how do people get infected? They get infected by inhalation or aspiration of the aerosolized water droplets, that is from showers, cooling towers, spas. After inhalation, the bacteria infect the lung macrophage and multiply there, and no person-to-person spread is seen. And the rare sources being potting, soil, compost. This is especially true for the longbeachii, and the dental practice via contaminated water lines. Dialysis units and hospital water pipelines are frequent source of contamination. So how to prevent this? Monitor your water quality in the hospital and public places. Disinfect the water systems regularly. Keep hot water above 60 and 50 degrees for distribution. Keep cold water below 20 and notify health authorities for cases so that they can trace the source. How common it is to present in pneumonia cases? If you look at all the community-acquired pneumonia, around 5% would be Legionella. Proportion is higher in ICU patients. Was previously one of the top 3 causes of severe CAP needing ICU, but less common nowadays due to better prevention and early treatment. Seasonal and environmental trends more common in late spring to early autumn, that is in temperate climates. But this is, as we said, this is for the temperate area. For the tropical areas, it could be more so in the winter months, or it can occur all the year round also. Increased incidence with climate change and more rain, higher temperatures and higher humidity, all these things can increase the incidence. Elderly are mostly affected, we have already said that. Regarding the pathophysiology, how it infects the lung, Legionella mainly affect the terminal bronchioles, that is the smallest of the airways. What they do is they cause a build-up of the inside the alveoli of inside of the macrophages, that is the immune cells, neutrophils, red blood cells and fibrin. This leads to swelling of the alveolar wall and sometimes tissue death and necrosis. So why knowing this matters? It matters because you will know from where you need to take the samples. You can't take a tracheal aspirate and expect to find the organism. You need a bronchoscopy. Legionella grows mainly inside the lung macrophages, but also infects the lung lining cells as well. How does Legionella infect and multiply? It uses the type 4 secretion system, that is T4SS, to inject 300 plus proteins into the host cells. So these proteins hijack the host cell function, helping the bacteria hide, survive as well as multiply. The immune system tries to fight back by toll-like receptors to detect the bacteria. This activates the NF-kappa beta pathway, which triggers the release of inflammatory signals. Apart from this, other immune cells invade, that is the dendritic cells, neutrophils, natural killer cells, they all help in the infection. So why do we use animal models for our research? Most of the research that we see is coming from cell cultures or mice models. Now, normal mice do not get Legionella pneumonia like humans do. So only special mice allow Legionella to grow in their lungs. So this is why we need more animal models for this research. Results from animal studies help, but they don't really replicate a human infection per se. Key virulence factors are the T4SS, as we have already discussed, the Pro-A, which is zinc metalloproteinase, which damages the lung tissue, helps the bacteria spread, MIP, that is macrophage infectivity potentiator, and flagellin. This helps the bacteria survive and avoid the immune attacks. The clinical relevance here is that the higher the amount of Legionella DNA in the sputum, the more severe the pneumonia is, as well as the ICU stay and hospital stay. Legionella can disrupt the normal balance of the lung bacteria, especially with ventilation and prolonged antibiotics, increasing the risk of severe infections. So how does the immune response affect the severity? A strong immune response, more severe the disease. Some patients develop immune paralysis. This is especially for those who need the mechanical ventilation. Severe cases may show a surge in the inflammatory markers, but later the immune is exhausted. So how is the human to human spread so rare? This is done because the Legionella evolved through infecting the protozoas. They are not really very acquainted with humans. Humans are essentially accidental hosts. So essentially we are the dead ends. So there is no adaptation for person to person spread. They are not meant to do all these things. This also means that antibiotic resistance is low. So they don't really try to grow or evade our system. So there is no ongoing selection pressure inside the humans for them. So how and is everything happening? The entry is inhalation into the lungs. Then you have cell invasion, that is the invasion of the macrophages where they survive and multiply. Then they use their virulence factors to do more damage. Then based on your immune response, you can get cured or can get more bad also. It also affects the microbiome, as we have already discussed. So what is the clinical picture like? So who gets this Legionella infection? As we have already discussed, there are people who are smoking, the people who have a lung disease before, diabetic patients, cancer patients, patients who have organ transplant, patients who are on immunosuppressive agents, and it is more common in men and in elderly. So these are the factors you must keep in mind when you suspect Legionella infection. So what are the main clinical factors? It presents as severe community acquired pneumonia. Legionella is more likely to cause severe CAP than other atypical bacteria. No single symptom is specific for Legionella, but a combination of findings suggests that it could be a Legionnaires disease. Regarding the typical features, you can have high fever, a relative bradycardia, you can have cough, which is often dry at first. Later, it can become productive. Shortness of breath, chest pain, distinctive extrapulmonary clues, or you can have GI symptoms like diarrhea, which is very common as a matter of fact. You can have nausea and vomiting. You can have neurological signs like confusion, agitation, headaches. You can have renal involvement like AKI, sometimes even rhabdomyolysis. Others like muscle ache and malaise can also be seen. Regarding lab findings, they are typical but not always and necessarily pathognomonic of it. Some are low sodium, that is hyponatremia, low phosphorus, elevated creatinine kinase, acute kidney injury, microscopic hematuria, and elevated ferritin and CRP. So these are the findings which you may correlate and with your clinical picture and history to get guided towards a Legionnaires disease. Finally, you have high WBC with lymphopenia. Next is imaging features. There is no such pathognomonic and unique feature to pneumonia produced by the Legionnaires. Early, you may find a patchy unilobular infiltrate. On progression, it can rapidly spread to both lungs, causing a bilateral interstitial pneumonia. Pleural effusion seen in 15 to 50%, usually small but not requiring intervention. CT scan, you can have large areas of consolidation than seen on X-ray, surrounded by ground glass opacities. Radiology may worsen in first week even if the patient is clinically improving. Don't change antibiotics based on X-ray alone. Extrapulmonary complications, as we have discussed, You can have cardiac involvement like myopericarditis, endocarditis. In neuro, you can have encephalitis, abscess, cerebellar ataxia. In GI, you can have pancreatitis, hepatitis, colitis, spleen involvement. Others, you can find cellulitis, necrotizing fasciitis, joint involvement, and disseminated intravascular coagulation. Apart from that, you can see that these type of extra pulmonary features are more common in patients who are immunocompromised. Extrapulmonary form usually spreads from lung infection via the bloodstream. Clinical features in immunocompromised patients are unusual clinical and radiological presentation like nodular opacities, cavitations. Both Legionella pneumophilia and non-pneumophilia species can cause very severe disease. It has a pretty high mortality rate up to 33%. May test negative on standard urine antigen tests. Cavitation occurs in 10% despite appropriate treatment being given. Course in the ICU, most ICU patients require ventilatory support, often present with multi-organ failure, septic shock, high rates of AKI, may need dialysis. High SOFA and Apache scores are very common in this patient group. So what are the poor prognostication factors? Age is definitely one, that is more than 50 years. Female sex is a worse prognostic factor. Renal failure, high CRP, severe hypoxemia, prolonged steroid usage, malignancy, immunosuppression, nosocomial infection are worse. And finally, a delay of more than 24 hours in starting appropriate antibiotic can be very, very bad. If you look at the mortality, overall it ranges from 14 to 18%. In ICU and immunocompromised, it can be as high as 40%, which is pretty high for community acquired pneumonia. Mortality higher in severe hypoxemia and ARDS, delayed therapy or multi-organ involvement. Co-infections can also be there like COVID-19, influenza and fungal infection. So testing can be done and should be done, especially if the patient is not improving. This indicates a worse prognosis. So how do we diagnose this condition? So the main diagnostic method is urine antigen, which is, we all know, very common. It detects the Legionella pneumophilia serogroup 1 antigen. The results are available quick within 30 minutes. And the antigen appears 1 to 3 days after symptom starts and stays detectable for weeks and months. Not affected by prior antibiotic usage, which is very important. Sensitivity is quite high, up to 90%, and specificity is almost 100%. Limitation though is detects only LP1, which is the antigen, and so misses out on other serogroups and species. And used mainly in severe pneumonia if there is an outbreak or travel history. May be less sensitive in hospital-acquired infection and immunocompromised patients. So a negative UAT, that is urine antigen test, doesn't really rule out Legionella, especially if your clinical suspicion is very high. Next is PCR on the respiratory samples. It detects the Legionella DNA from the bronchoalveolar lavage and other respiratory samples, can identify all species and serotypes. Sensitivity is very high, 99%, and specificity is also good. Useful when you have non-LP1 infections. And for hospital and immunocompromised. DNA load correlates with disease severity, may help monitor the treatment response, can be used on pleural fluid as well as biopsies, even for extrapulmonary cases. So PCR can be positive even if the UAT is negative. Use both tests if the suspicion is high. Regarding culture, this is the gold standard, but it's slow, takes several days and needs special media, detects all types of Legionella, confirms the diagnosis, but it is mostly used for study purposes. Important for outbreak investigation and public health only. Always try to collect sputum and lavage for culture in severe cases, even if you have started on empirical antibiotics. Whole genome sequencing, it is again a research and a public health tool, not really used for clinical practice. Next, you have the when should we test for Legionella? Severe community acquired pneumonia patient coming to the ICU with shock and multi-organ failure, you should do a Legionella test. Pneumonia with GI and neurological symptoms like hyponatremia, then you should do a test. Or if there are outbreaks, do a test. Hospital acquired and immunocompromised patient, use both UAT and PCR. Stepwise diagnostic approach is, if you have a patient who is having severe CAP, then order a UAT. Send respiratory samples and check for the PCR. If the UAT is negative but the suspicion remains, rely on PCR and culture, especially if the patient has acquired it in the hospital or the patient is immunocompromised. Monitor the DNA load if available. In those cases, you can track the disease progress. So these are the various tests that are available that we do. what it detects and what is the time it takes, what are the pros and what are the cons. So finally, how do we manage this? This is very important. The principal management has to be antibiotics started early within 24 hours and ideally within 8 hours. This will improve your outcome. Antibiotics must concentrate in the alveolar macrophages, which is the site of infection. Always include Legionella active antibiotics in your empirical cover for severe CAP. So what is the first line? It is fluoroquinolones. Levofloxacin 750 IV once daily or 500 twice daily. Macrolides, azithromycin, which is again the preferred macrolide, 500 milligrams IV once daily. Clarithromycin, which is an alternative, 500 milligrams IV twice daily. Spiramycin, which is not really available, you can use if it don't have azithromycin, then 3 million units IV 3 times a day. Combination therapy, consider using a combination of levoflox with macrolides if the patient is in shock, if the patient is immunocompromised, if there is failure of monotherapy. Rifampicin is not really recommended but due to its more side effects and no real proven benefit. And in India, we use it for TB, so better not to use this. Regarding the duration of therapy, in severe cases, at least 10 days is required. If immunocompromised, you can give up to 3 weeks. In mild cases, a short course is enough with oral azithromycin. Regarding monitoring, clinical response may be slow. Improvement may take 5 to 7 days, even on correct antibiotics. Switch to oral when the patient is stable or vasopressus and improving oxygen. In non-resolving cases, check whether there is empyema or superinfection or co-infection. You can use your lung ultrasound over here. Supportive ICU care needs to be done if the patient is having ARDS. Non-invasive patient often will fail, so go for intubation. If your standard ventilation strategies fail, you can go for ECMO as well. Watch for multi-organ failure at all times. Special consideration is steroid therapy, not routinely recommended here. Evidence for benefit is unclear and risk may outweigh the benefits, especially since prior steroid is a risk factor. Procalcitonin not useful, so don't do it. Infection control, notify your public health authorities because it could be a potential source of a outbreak. Hospital water management is key to prevention. Antibiotic resistance is rare. No need for routine susceptibility testing. Only few cases have been reported and unusual, so no need to go through it. So to summarize the management, start early. Drug of choice is levoflox or azithro. Go for a combination if the patient is severe. Duration can be 5 to 7 for normal cases. To severe cases, you can go up to 3 weeks. Switch to oral once stable. Do your supportive therapy. Don't give steroids. Notify your authorities. Monitor your progress. And no need to worry about resistance. So this is a infographic which is summarizing all things that I have said. You can take a screenshot or see it in your leisure. Thank you for your patience.